Hello, today we're going to talk about coronary artery occlusion from Kawasaki disease. My name is Daniel Rodriguez Guevara. I am fourth semester, parallel D. To begin, we're going to talk about the definition. The Kawasaki disease, also called mucocutaneous lymph node syndrome, is a vasculitis of unknown etiology that generally occurs in infancy and childhood. The acute illness is self-limited and is characterized by high fever, non-exudative conjunctivitis, inflammation of the oral mucosa, rash, cervical adenopathy, and bindings in extremities, including swollen hands and feet, red palms and red soles, and later subungual peeling.
Of the cause, but unfortunately today we actually still don't understand what causes Kawasaki disease. And the geographic and genetic influences are still really unknown. Now, as the years have gone on, Kawasaki's disease has also been given the name mucocutaneous lymph node syndrome. And that's quite a very long description, but it actually really makes sense based off of the findings and symptoms. The word mucocutaneous refers to mucous membranes. Mucous membranes are wet surfaces such as the mouth, and cutaneous refers to skin. So, for example, skin on your hands or on your feet or on your body. Another mucous membrane affected is the eyes. Now, where does the word lymph node come from? Well, commonly in this disease, you can see swelling of nodes in the neck. These are lymph nodes. Specifically, they're known as cervical lymph nodes. Cervical means neck. Now, as I mentioned earlier, this is a medium vessel vasculitis. A vasculitis is an inflammation of blood vessels, and it's believed to be caused by the immune system, though why the immune system decides to damage the blood vessels in this disease is really not known. The diagnosis is essentially based off of the clinical symptoms that you see. You can see red eyes, which is known as conjunctivitis, a more prominent redness of the mouth. This is oral erythema. You may see redness of the palms and redness of the soles. And you may also see a red body rash. So the common theme in this is rash, red rash. So now if we see some sort of rash or redness, and we also see a fever more than 5 days, and a child is less than 5 years old, you should be thinking about Kawasaki disease. Now this is actually a disease that's very important to diagnose early. The reason for that is you can see symptoms affecting the heart if this disease continues for a longer period of time. Remember, Kawasaki disease is a vessel disease, inflammation of blood vessels. So if you see damage to some of these blood vessels, you can get clots in the blood vessels of the heart, which causes the heart to not be able to contract. So maybe it can contract well up here, but down here, it's not contracting as effectively. Remember, heart cells need blood, and if they're not getting their blood, they're going to die, and they can't contract anymore. This cell death of heart cells is called myocardial infarction. Myocardial infarction. This is also known as a heart attack. Along with myocardial infarction, you might have cell death of the valvular muscles. These are known as the papillary muscles of the heart. If you cause damage to these, you're not able to pump blood effectively out of the heart because the valves are damaged and not functioning properly. Something more severe that might be seen is known as pericardial effusion. Pericardial effusion is a collection of blood outside of the heart. This is caused by blood vessel rupture. Blood pours out of the heart because of a ruptured blood vessel and accumulates around the heart. This is a very serious issue. And so it makes sense if you see a kid with fever who's less than 5 years old and has all these red rashes, you should be very serious about considering Kawasaki disease. Now, since we don't understand the cause.
Okay, now we're going to talk about applications in medicine. Children with Kawasaki disease are at risk for serious cardiovascular sequelae, particularly coronary artery abnormalities, which can lead to myocardial ischemia, infarction, and sudden death. The risk of developing coronary artery abnormalities is highest among children with Kawasaki disease who are not treated early in the disease with high-dose intravenous immunoglobulin. Thus, initial management of patients with Kawasaki disease is focused on early diagnosis and treatment with intravenous immunoglobulin. Next, we want to show a video about the relation in nowadays of the Kawasaki disease associated to a very famous virus in this year.
That most of them have, maybe not all 6 symptoms, but a variety of them. And those include a fever for more than 5 days, a rash, a red rash that's concentrated either in the axilla or the groins. They have a strawberry red tongue, red eyes, swollen or peeling feet, and a swollen lymph node. Now, again, these patients may not have all 6 symptoms, but many of them have 4 or 5 of these symptoms that bring them to medical attention. The children do not seem to have problems with breathing, as we have seen in many adults with COVID-19. Instead, they may have abdominal pain or diarrhea or vomiting that shows up along with these other symptoms. This is important to bring your child to medical attention because they are at high risk for having other problems beyond the rash and the fever. Children with Kawasaki syndrome and children with this syndrome that seems to be related to COVID-19 ultimately are having inflammation in their heart also. So at Phoenix Children's Hospital, we know how to treat Kawasaki syndrome. And if your child has a problem like this, we will be doing things like using a sonogram to look at the heart and treat with medicines that we know have been effective in treating Kawasaki syndrome. This can be a very scary time, and bringing your child to a hospital can seem daunting, but it's very important that you seek medical attention and either bring them to attention to your pediatrician or through the emergency department here at Phoenix Children's Hospital. Thank you very much.
Okay, now we want to talk about pros and cons. For children in the acute subacute phase of illness of those who are not candidates for mechanical restoration of flow in the cardiac catheterization laboratory, we administer systemic recombinant tissue plasminogen activator, low-dose aspirin and heparin, which is adjusted to a target antifactor 10A level and or activated partial thromboplastin time. In patients with clinical signs of coronary ischemia, including evidence of reversible ischemia and stress testing, we suggest coronary artery revascularization, either by PCI or coronary artery bypass grafting procedure. The goals of the coronary revascularization are to relieve symptoms of angina and reduce the risk of myocardial infarction or sudden death.
Adults are more likely to present with incomplete Kawasaki disease. Infants are at greater risk for cardiovascular complications, possibly due in part to a delay in diagnosis and intervention. Infants 6 months of age or less, with unexplained fever for at least 7 days, should be evaluated for Kawasaki, even if they have no clinical findings of Kawasaki disease. Additional clinical and laboratory features are often used to guide diagnosis in children who have fewer than 5 criteria or incomplete Kawasaki disease. No laboratory studies are included among the diagnostic criteria for typical Kawasaki disease. But the presence of compatible laboratory features strongly supports the diagnosis. Laboratory findings suggestive of Kawasaki disease include the following: elevated acute phase reactant CRP above 3 mg per deciliter, or ESR above 40, WBC count above 15,000 per microliter, normocytic, normochromic anemia for age, platelet cell count above 450,000 per microliter after 7 days of illness, non-neutrophilic sterile pyuria due to urethritis, serum alanine aminotransferase level above 50 units per liter, serum albumin less than or equal to 3 grams per deciliter. The presence of cardiac abnormalities detected by echocardiography provides support in ambiguous, incomplete cases of Kawasaki disease. Children with Kawasaki disease can have concurrent infections, particularly with viruses circulating in the community at the time of their diagnosis. The major complication of Kawasaki disease is coronary artery abnormalities including aneurysm. Acute myocardial infarction is the main cause of death. Please like.
Now, the issue applied in Ecuador. In the last of 2020, the Kawasaki disease has been associated to the virus of COVID-19. So in Ecuador, the cases appear in 8 provinces. Guayas with 10 cases, Manabí with 8 cases, Pichincha and Los Ríos with 7 cases each, and in Azuay, Santo Domingo, Los Áchilas, Tungurahua, 1 case each province. All this data recopilated until July of 2020. The source of information that I take on of this data does not report if the patients have a successful treatment to the Kawasaki disease, so it's unavailable to know if they are well now.
Fever is considered an obligatory manifestation of Kawasaki disease. There should be no other explanation for the fever, and while there is some leniency in regards to the duration, it is expected to have been present for at least 5 days. While there is a large variety of manifestations that are caused by Kawasaki disease, only 5 signs of mucocutaneous inflammation are included in the criteria. Within the first few days of illness, children may develop non-suppurative anterior cervical lymphadenopathy. There can be redness of the overlying skin, but pain and tenderness do not usually occur. At least one lymph node greater than 1.5 centimeters in diameter is required for the diagnosis, and in actuality, only a single lymph node is usually enlarged. Diffuse lymphadenopathy and splenomegaly are uncommon and should put the diagnosis into question. The rash may begin on the trunk and then spread to the rest of the body. If an antibiotic was administered, then it may be erroneously attributed to an allergic reaction. The rash is usually maculopapular and erythematous, but a variety of types may occur, such as erythema multiforme or a morbilliform or scarlatiform rash. Vesicles and bullae, however, do not usually occur. The conjunctival injection associated with Kawasaki disease typically begins within days of onset. It is usually bilateral, bulbar with sparing of the limbus, and non-exudative. Although painless, there may be photophobia, and uveitis, when present, should increase suspicion of Kawasaki disease. Mucositis develops as Kawasaki disease progresses. There may be marked erythema of the lips, pharynx, and tongue. The lips may become swollen with cracking and bleeding, and the erythema of the tongue in combination with swollen papillae can give an appearance often described as a strawberry tongue. About 1 week into the illness, the hands and feet may become diffusely swollen with erythema of the palms and soles. Discoloration of the skin occurs about a week or 2 later. If the fever criteria and 4 or 5 of the clinical criteria are met, then the diagnosis is established. Now, if a clinician has a great deal of experience in treating Kawasaki disease, then the diagnosis can be established prior to the 4th day of illness.
Now to the conclusion. The management of patients with Kawasaki disease and coronary artery abnormalities, such as coronary occlusions, is aimed at preventing and treating coronary artery thrombosis. There are no available randomized trials of antithrombotic therapy in children with Kawasaki disease and coronary artery abnormalities. Management is based largely upon adult data for secondary prevention of coronary artery disease. For patients with Kawasaki disease and coronary artery abnormalities, the prognosis depends upon the size of the aneurysm. Small aneurysms generally have favorable prognosis with a low risk of myocardial ischemic events and mortality. In contrast, large and giant aneurysms have a high risk of morbidity and mortality. Up to 1/2 of such aneurysms become obstructed, increasing the risk of myocardial infarction